I'm going to talk about myeloma today. I'm really going to focus on, in the majority of the talk on the newly diagnosed patient. I'm going to really give our approach about how we manage these patients. And again, I'm going to actually focus more on the transplant patients than the non-transplant patients. There might be some overlap from the transplant talk yesterday, but from a learning perspective, hearing similar data 2 days in a row should be very effective. And then at the end, I'm going to touch on some of our new drugs, ones that have been approved, and then sort of the next level of drugs that are yet to be approved, but certainly very exciting. Here are my disclosures of my grant and research support, as well as consulting. These are our objectives that we have that are outlined in your program. There's probably over 70,000 people in the United States alive with myeloma right now. 22,000 people every year are diagnosed. We still have 10,000 deaths, or 10 to 11,000 deaths every year. Median age, depending on which series, is somewhere between 65 and 70. Slightly more common in men than women, significantly higher incidence in African Americans than Caucasians. And in fact, we've looked at SEER data. African Americans on average present 10 years younger. We don't understand why. We're participating in a population-based study to try to determine why there's these differences. We used to think of myeloma as a single clinical entity defined by, again, sort of the current definition of symptomatic myeloma is have clonal plasma cells in the marrow, typically greater than 10%, a monoclonal immunoglobulin in the serum or urine. We used to say that about 3% of patients were non-secretory. Now, with the advent of the serum-free light chain assay, that number is much, much smaller, and it's much less than 1% of patients won't have any abnormality in their serum or urine. And then in the setting of those two with symptoms of myeloma, we use the acronym CRAB criteria, C for hypercalcemia, R for renal dysfunction, A for anemia, and B for lytic bone disease. And here you see the classic calvarium of a patient with myeloma with the moth-eaten appearance. And again, very, very important to remember, in myeloma is a pure lytic bone disease. There is a lot of we've really started to understand the biology of this, where there's not only activation of the lytic bone disease in terms of activation of osteoclasts, there's active inhibition of the osteoblast, and it appears that the osteoblast from a methylation standpoint and epigenomic standpoint are permanently silenced. And so that's why, even though your patient's in remission, those holes in the bones never go away. And the other clinical things that we often see in myeloma are things like increased risk of infection and so forth. And then we still know, while it's not most common, we can see plasma cell leukemia as well as soft tissue plasmacytomas. So that's our clinical disease, and we used to think it was all one clinical disease. And then over the past 10 or 15 years, we've started to understand that the biology of myeloma is obviously more complicated than that. And the first division in myeloma was understanding whether it was a hyperdiploid myeloma, where there typically weren't translocations of the immunoglobulin heavy chain, and then non-hyperdiploid, where we typically would see translocations. The things like the 414 translocation, which is associated with high-risk myeloma, 1114 translocation, and so forth. And then there was somewhat of an overlap, where some patients were both hyperdiploid as well as have primary IgH translocations. And then it got a little bit more complicated than that with the advent of gene expression profiling. This is just one group's view of gene expression profiling. This comes from the Arkansas group, where they were able to divide myeloma in somewhere between 7 and 10 different groups. and it looks like in this group over here, this PR group, the proliferative group, this represents a highly proliferative myeloma. This is the group of patients who have abnormal conventional cytogenetics. This is the group of patients who have, if you do this assay, an increased plasma cell labeling index. And this is the group of patients who has median survivals on the order of 2 to 3 years. And then there was a whole other biology. What we've done at Emory is take it one step further. Our colleagues in the lab have coined the term myelomics, where we look at myeloma as discrete genomic, proteomic, and epigenomic abnormalities. And this is just one example of what's known as a Circos plot, where we look at all of the different abnormalities from mutations and copy numbers. And we're learning that, again, myeloma is not one specific disease. If you take a group of patients with myeloma, there's an enormous amount of heterogeneity. And in fact, if you take an individual patient with myeloma, even within the myeloma, there's an enormous amount of heterogeneity. And so it's within this context of a single, what appears to be a single clinical disease and underlying diverse abnormalities that we're really building our research program. So again, we've had this enormous improvement in understanding the biology, but it's very interesting. Over the past 10 years, while our improvement in understanding biology is advanced, we also have a parallel, but to date yet unrelated, a parallel improvement in treatment. Prior to the mid-90s, the mainstay of therapy was the combination of melphalan and prednisone, and in a meta-analysis that looked at over 6,000 patients from many, many studies comparing melphalan and prednisone to more intensive chemotherapy regimens. Nothing was superior to melphalan and prednisone until the IFM 90 study, where high-dose therapy was shown to be superior than a melphalan and prednisone-like regimen. And then as we've gone over the past now 10, 12 years with the advent of new therapies, drugs like IMiDs and proteasome inhibitors and beyond, we have had an enormous improvement. And that's what I'm going to talk about today. This is a concept that I think a lot of people actually have a hard time believing in myeloma when we trained in the era of ineffective therapy in myeloma. But now within an era of more effective therapy in myeloma, we're seeing more and more often that this remains true, is that, and it makes sense, the deeper response, the longer this patient's going to remain in remission. And we currently have categories like PR, the 50% reduction, VGPR, 90% reduction, near CR, where we have elimination of the monoclonal protein, but we can still detect it on immunofixation, CR, where we can detect no abnormal protein or clonal plasma cell, and stringent CR, where the free light chain normalizes. And there's levels below this. There's molecular CR, minimal residual disease, and lower levels of disease, which would portend longer and longer remissions. And maybe in some cases, these patients will never have relapse, and we can call them cured. So when we think about myeloma, this is the structure of how we think about it. We first have to make the decision whether the patient is a transplant-eligible patient or ineligible. But whether they're transplant-eligible or ineligible, we have to decide on initial therapy. And then typically in the transplant patient, we move for consolidation. And when I say consolidation, what I'm really talking about is autologous transplant, maintenance therapy. And in the transplant-ineligible patient, typically the consolidation maintenance is the same. And then always we have the treatment of relapse disease, and underpinning this is supportive care. And it can be as low tech as our communication skills, and also as drug-based drugs like bisphosphonates, which we've now have learned over the past several years are actually associated with an improvement in survival in patients with myeloma. And so, again, the first thing we have to do is decide whether the patient is a transplant candidate or not. I'm going to talk a little bit about how we make that decision shortly. Those patients who are a transplant candidate would receive a non-transplant candidate, typically a fixed course of standard therapy followed by either maintenance or no maintenance. And I think there's actually much more controversy in the non-transplant setting of should we give ongoing therapy or not. In the transplant candidate, I probably should update this slide, but typically there's a non-melphalan-based 4 to 6 cycles of a non-melphalan-based therapy, and then followed by stem cell harvest and transplants. And I just saw an old friend. Hey, Joanne. How are you? Sorry. Okay, so in terms of our modern therapies, the question is, what are our modern therapies based on in terms of clinical trials? When I was training at the VA many years ago, our standard of care was thalidomide and dexamethasone as for newly diagnosed patients, and which was the standard of care in Europe, and actually continues around the world to be very much one of the standards. Thalidomide outside of the United States is a very inexpensive drug. And so this was a Italian study that looked at the combination of bortezomib thalidomide dex versus thalidomide dex, and what they showed in this study was that there was a significant improvement in progression-free survival, and there was no proven, there was no difference in overall survival, at least at 3 years. Again, with transplant studies, I think looking at 3-year survival is probably too early, but nonetheless, there was a clear benefit in terms of response rate and progression-free survival, and not yet improvement in overall survival. The HOVON study looked at the other standard when I was training at the VA, which was VAD, versus a combination of bortezomib plus doxorubicin and dexamethasone. So exchanging out the vincristine for bortezomib. And then in this study, there was these patients who had the bortezomib doxorubicin dex, then had transplant, and then a bortezomib maintenance, 1.3 milligrams per meter squared, given once every other week for 2 years, versus the VAD patients who then had thalidomide maintenance. And so the way I think about this study is the experimental arm is newer therapy, and the control arm would be considered older therapy. And here, in this study, there again saw this small but real improvement in overall progression-free survival for the entire group, and then a small but I guess statistically not quite there yet improvement in overall survival. When looking at subset analysis of this group, if the patient had renal insufficiency, that was the group of patients who had a dramatic improvement in their survival. And this blue arm here are the renal insufficiency patients who are on the VAD followed by thalidomide, and here in the red arm are the renal insufficiency patients who were randomized to the bortezomib arm. And then the same thing, I'll just focus here. I know it's sort of small, but the line is so dramatic. This bottom 2 panels, E and F, are the deletion 17p patients. And notice here in this blue line, deletion 17p randomized to VAD did very poorly, and those who were randomized to the bortezomib followed by bortezomib maintenance did almost as well as the standard risk. And this is in our high-risk setting, the deletion 17p. And so I showed you 2 studies where there was a bortezomib-based induction therapy, and there was a clear improvement in progression-free survival and minimal, if any, improvement in survival. And one of our colleagues, Dr. Nuka at Emory, who's a whiz with the computer, looked at 4 randomized studies that had a bortezomib arm versus a non-bortezomib arm. He presented this data initially at ASH 2011, and now this is just published in Cancer. And what he showed in this meta-analysis is that though that group of patients who were randomized to the bortezomib treatment arm had actually an improvement not only in progression-free survival, had an improvement in overall survival. And then when he did some deep diving into this, if he pulled any individual study out, it still supported the data. So this gives us information that there is, again, a small but real improvement for an entire population getting, I guess, our newer therapies up front, in this case, bortezomib. And so what have we been doing over the past 5 years, or more, 5 to 7 years now, is using a combination of lenalidomide, bortezomib, and dexamethasone, sort of taking that VTD approach, translating it to more modern therapy that we're able to use here. And in this study, this has now been published in Blood in 2010. If you look at, whether you look at the entire population, which included a phase 1 group, or just look at the phase 2 group alone, where we're at the maximum planned dose, the 75% of patients achieved at least a VGPR, and every patient, at least on this study, responded to therapy. And so we were lucky enough to participate on this study, and once the study ended, this became our own de facto standard of care. And then we just recently presented this at ASCO this past summer, and we asked the question, how did our patients do? One of the things that we noticed, again, with these patients is that with everybody responding, 3 out of 4 patients going into a VGPR, we asked the question, did everybody need an upfront transplant? Now, this was not a randomized study. This was the choice of moving forward with transplant was based on the physician and the patient's preference. But in the 222 patients that we looked at, 138 received early transplant, and 84 of the patients had a delayed transplant. Now, again, this was not a randomized study, but in general, we had guidelines of who would be a candidate for the delayed transplant. And in general, we said the patient could not have high-risk disease, and so again, we've sort of selected a good patient population. The patients had to have responsive disease, and then thirdly is the patient had to tolerate therapy. So if we delayed transplant, we could get, instead of that 4 cycles of induction, we could get closer to 6 to 8 cycles of induction. So again, these 84 patients do represent somewhat of a select group. And if you note here, the responses were excellent. It's not a randomized study, but in the overall response rate for those who had delayed was 100%. In the early transplant, the response rate was 94%. Again, we found in multiple studies since the initial study that the response rate's probably not 100%. It's probably closer to about 95%. But again, we had our VGPR rate higher in those patients that we were able to delay transplant, 77% versus 62%. And it's very interesting here. There's very old, high-quality randomized data that says whether we do the transplant has no impact on overall survival. What we showed here is that whether we do the transplant or not actually has no impact on progression-free survival. And if you look at overall survival for this entire population, the delayed transplant did better. This, again, I'll reiterate, this is not a randomized study. This is a select group of patients who did not have high-risk disease, tolerated therapy, and had responsive disease. But they did very well with coming out to 5-year survivals on the order of 90%. Those patients who went to early transplant, which included a variety of patients with high-risk disease, still had 4 to 5 year survival on the order of 80%. Oops. So what's next in terms of induction therapy? There is now been published looking at our newer proteasome inhibitors, carfilzomib. What's great about carfilzomib is that we don't have to worry about peripheral neuropathy anymore, and this regimen is very effective. Again, 98% response rate, a near CR, and 62%. Ixazomib is a drug that's not yet approved, but ixazomib is an oral proteasome inhibitor. And again, there are randomized studies comparing ixazomib plus lenalidomide dex versus lenalidomide dex. My colleague, Dr. Loniel at Emory, has led a international study of looking at a monoclonal antibody, elotuzumab plus lenalidomide dex, and we participated in a study, or we led a study, where we added an HDAC inhibitor to RVD. And so I don't think the story is over in terms of what the optimal induction therapy is. Our approach is going to be to use an IMiD, to use a proteasome inhibitor, and still use dexamethasone. And the question is there something else that we can use on top of that? So switching to consolidation, Again, when I say consolidation in the transplant setting, what I'm really talking about is autologous transplant. And again, the purpose of autologous transplant is to deliver a very high dose of chemotherapy to hopefully eliminate as much of the malignancy as possible. And then the transplant itself has no therapeutic benefit. It just really is sophisticated supportive care. We need to be able to find regimens where we can still mobilize stem cells, and then we need to make sure that we have stem cells that have adequate engraftment. So who is a transplant candidate? I guess the question is really who's not a transplant candidate. In European countries, they have a hard cutoff of 65 years old, but we know that there are many 65-year-olds and older in late 60s and early 70s whose biologic age is not equivalent to their chronologic age. And so those patients who have poor performance status, obviously those patients are unable to perform their ADLs. Decompensated comorbidities. The main comorbidities we talk about are liver, lung, and cardiac problems. Those patients, even on dialysis, can still move forward with transplant. And I would say probably the single factor that's associated with ineligibility for transplant more than anything else is the social economic factors. And it takes a lot of effort. It takes a huge personal support system to move forward with a transplant, and I would say that it's much less likely age and comorbidity associated than the socioeconomic factors. This is a busy slide, but this is the study that led to the widespread use of transplant. This is the IFM90 study, where there was an improvement in CR, an improvement in event-free survival, and an improvement in overall survival. A study done just afterwards through the MRC showed very similar results. And in these studies, there was an absolute 1-year overall survival benefit in transplant. So I had mentioned we did a retrospective study of delaying transplant. There are prospective studies now using modern therapy asking the same question. This is a study that's yet to be published but presented several times by Antonio Palumbo, looking at lenalidomide and dex, and then there's 2 randomizations. The first randomization randomizes patients to a tandem transplant, or they get 6 cycles of the combination of melphalan, prednisone, and lenalidomide. And you'll note here that the progression-free survival is superior to those patients who had early transplant without any statistical difference in overall survival, but there is a numerical 9% difference, at least here. But again, there's a second randomization of maintenance versus no maintenance, and I'll show you shortly that data. Okay. So this study asked the exact same question, but I think uses a better experimental arm than melphalan, prednisone, and lenalidomide. And the experimental arm is using RVD. So in this study, all patients get RVD. Then they're randomized and stem cell collection, and then early transplant versus completion of 8 cycles of RVD. Everybody gets lenalidomide maintenance, and this study is ongoing. And the good thing about this study is that it's an over 1,000-person study, and we're going to be able to answer the question based on risk and responsiveness, who really should go to early transplant and who it's okay to delay. There's another question that's open. This study is about to close. This is led by the BMT CTN network, asking the question, should we do tandem transplants? Or if not tandem transplants, should we do some type of consolidation chemotherapy before maintenance? So all patients get single transplant, and then a third of patients get a second transplant, a third get RVD and followed by maintenance, and a third skip the second transplant, skip the consolidation, and go right to maintenance therapy. I think this study will be very important also in determining how we manage patients post-single auto. And so the other really exciting thing in myeloma today is maintenance therapy. I think we've seen a lot of study of maintenance therapy. We've been studying maintenance therapy for 30 years, going back to interferon and steroids. This looks at thalidomide maintenance, Here we see improvement in progression-free survival, no improvement in overall survival. Here's another study that was done in the Canadian NCI, improvement in progression-free survival, no improvement in overall survival. This is probably the best study in the maintenance setting. This study was powered to look at overall survival, and more importantly, they looked at quality of life. And what they found is there's no improvement in overall survival, and there's a decrease in quality of life in those patients randomized to thalidomide. And so I think at this point, we really like to avoid thalidomide as a rule in maintenance therapy for this issue. So what have we been doing for the past several years? This publication came out about 18 months ago, and there's two publications looking at lenalidomide as maintenance therapy. This is the French study where they had 2 cycles of lenalidomide, what they call consolidation, followed by randomization to placebo versus len. And here you see a really dramatic improvement in progression-free survival, and at this time, no improvement in overall survival. The problem that we saw here is a small but real increase in secondary malignancies, and we saw them in both hematologic as well as non-hematologic malignancies. And so this is sort of an ongoing thing that we are monitoring. In the United States, study with a very similar design. Again, same improvement in progression-free survival. And here we did see an improvement in overall survival. And so this third study, I just showed you this a minute ago. We looked at the initial randomization, looking at consolidation. Then there was a second randomization of maintenance versus no maintenance. And again, this was lenalidomide, 10 milligrams a day. Despite the other 2 ones had continuous lenalidomide, this study had 3 out of 4 week lenalidomide. And here we saw they were evenly distributed. And what's very interesting is that there was really no change in the response rate by using low-dose maintenance therapy, but there was a significant improvement in progression-free survival. Did I skip a slide? Sorry. Yeah. So you see here, even though there was no difference in response, there was a significant improvement in progression-free survival. And in this study, again, now this is 2 out of 3 studies where we did see an improvement in overall survival. So let's think about this study as a whole. And if you're a statistician, just close your eyes and close your ears, okay? But they put the data together. They said it was essentially a matrix. You have 2 randomizations, early transplant, plus minus early transplant, plus minus maintenance. If you look at the early transplant plus maintenance, it's the best in terms of progression-free survival and overall survival. If you look at non-transplant therapy and no maintenance, it's the worst in terms of progression-free survival as well as overall survival. And so I think we're seeing more and more. Now this is 2 out of 3 large, high-quality randomized studies that do show an overall survival benefit, even though we saw that small but real increase in second malignancies. And then getting back to the study I showed earlier, this is that HOVON study where it was bortezomib induction, bortezomib maintenance. And here, again, same data, but there's this small increase in survival that depending on when they looked at it, they saw a statistical improvement in survival. So I think more than anything, this tells me that bortezomib as maintenance therapy with 1 dose given every 2 weeks for 2 years, at least is feasible and is no worse and likely better than thalidomide maintenance. Unknown whether we should use bortezomib or lenalidomide. That question has not been asked. And so I think combination therapy based on the heterogeneity of underlying biology is the way to go in induction therapy. Transplant remains important, and I think we have an improvement in survival. And I'm really going to wrap things up, and I just wanted to note that we now in the past, it's more than a year, past 18 months, we have approval of new IMiDs. Pomalidomide is now available, very effective. I'd encourage to review that. We have new proteasome inhibitors I've already mentioned, carfilzomib, approved for use in the relapse setting. And then I think there's going to be a lot of excitement in monoclonal antibodies. We're so used to rituximab. We've been using rituximab for 17 years now. There are monoclonal antibodies in myeloma, targeting things like CS1, CD38, which I think are going to make a major impact on patients. And with that, I'll end, and thank you very much for your attention.